Hello, I'm Antonio Artigas from Spain, and I'm a member of the board committee of the Global Sepsis Alliance and the chairman of the translational lab in my hospital. And it's a pleasure and honor to chair this session on sepsis in emergencies and humanitarian crisis. I think this will be a very exciting session. I hope that you will not be too tired after this long day of presentations. And I would like to thank all the sponsors to make this possible. So I would like to introduce the first speaker. The first speaker is Janet Diaz. Janet, he will present the Filovirus and sepsis, optimizing management during outbreaks. Janet is a specialist in intensive care and pulmonary medicine, and she's an expertise in clinical medicine and medical education and quality improvement. He has been working in WHO as a lead for clinical management and operation unit in the health emergency program. So, Janet, the floor is for you.
Thank you so much, Antonio, for the introduction, and good morning, good afternoon, good evening, colleagues. Really nice to be here, and thanks to the Global Sepsis Alliance for conducting this Sepsis Congress. It's my pleasure to be here. I'm going to keep moving here. So what are the objectives of this talk? First, I want to describe why filovirus outbreaks are a public health emergency, describe what are the clinical and immunological characteristics of filovirus-associated sepsis, and then how do we best manage filovirus outbreaks using a holistic and integrated approach to reduce mortality. So the virus itself, for those of you that are not familiar with it or haven't thought about it in a while, this is the filovirus family. It has two big buckets of genus, I guess, or subfamilies. The Ebola viruses, which many of you may be familiar with, that was the cause of the big West African outbreak in 2014, and that includes Zaire virus. And then also recently, we've been having more outbreaks of the Sudan Ebola virus. And then the other bucket is Marburg viruses, which also we've recently had multiple outbreaks over the past few years. This is a complex slide, but I think it was one that I wanted to show because it's showing on the x-axis a timeline. So really, since the detection of filovirus in humans, how many outbreaks we've had, and there you see Marburg detected in 1967, all the way up to the present time, where currently we are having an outbreak of Sudan virus in Uganda. And there you see on the y-axis the case fatality ratios. And these vary between outbreaks, and you can see some low, some very, very high, a lot that are actually very, very high, above 90 or 100% over the years. I did want to highlight the 2014 West African outbreak, 2013 West African outbreak, and highlight there where the average CFR was around 40%. So that was the largest one, and I think it affected over 28,000 people in West Africa. The next one I wanted to highlight is the next second largest outbreak that occurred from Ebola Zaire virus, which was in the Democratic Republic of Congo. And that outbreak had affected around 2,500 individuals and resulting in a CFR of around 42%. And the reason I wanted to highlight that was because that's actually where a very high-quality clinical trial was conducted, the PALM trial, which gave us actually high-quality evidence for some effective monoclonal antibodies against Zaire virus, which I'm going to describe later. So it was a hallmark trial. Subsequently to that, WHO was able to publish in 2019 our optimized standards of care, which tried to standardize care across treatment centers and across outbreaks for filovirus. And then I want to follow up with a few other outbreaks that have been recent. The Sudan-Uganda virus outbreak in 2022, which had a CFR of around 40%. There, with use of investigational antivirals and monoclonal antibodies against Sudan Ebola virus through the MURI expanded access protocols, including the standard of care. And then one in Equatorial Guinea, which was a Marburg virus outbreak, the CFR there, 70%, quite high, but there was initiation of access to investigational products under MURI and expanded access protocols. And then highlighting on the red, because I wasn't able to add it to this graph, is the Rwandan outbreak of Marburg virus last September, and that actually had a CFR far low as 22%. And standard of care there actually included critical care, and it was the first time in filovirus outbreaks in the African continent where invasive mechanical ventilation was used to manage patients. And they also used investigational products under expanded access protocols and were able to successfully start a randomized controlled trial. The CFR in Tanzania for the recent Marburg outbreak, unfortunately, though, was 100%. That was a very small outbreak with only a couple of patients making it to a treatment center before the outbreak ended. And then the Ugandan outbreak of Sudan virus, which is ongoing, but almost complete with follow-up with the CFR of 28% up to date. And that outbreak being managed with optimized supportive care and access to investigational products under expanded access. So why do I go through that? And I think it was important for us to try to understand the variability in mortality and outcomes. And there were many lessons learned from West Africa, which actually, were the impetus for us to standardize and improve the standard of care. And in West Africa, there are, case series of different treatment unit experiences. And here's one from Kenema in May to June of 2014, showing a 95% of deaths in patients older than 45 years, and as well as those with very high viral loads and those with organ failure, including renal and liver failure, so quite high mortality. And many suggested at that time that was because the management was focused just on isolation and not really on treatments, not really on optimizing standards of care. And then we know from that same outbreak, those small number of patients that were transported in emergency transported to the United States or to Europe, where they were treated in critical care units, receiving advanced supportive care interventions, some with ventilator assistance, others with dialysis, and also access to experimental investigational products, where the death rate of those critically ill patients was 18.5%. So here, stress, the observer suggesting that the management focusing on isolation and, safe care, as well as treatment with critical care, optimized supportive care, and investigational products. So since then, so we go back to more present. So from 2014 to 2018, 2019, leading into the DRC outbreak in 2018, 2019, the real focus of our work with WHO and our partners and the Ministry of Health of the Democratic Republic of Congo was to really standardize the standard of care across the treatment centers, across partners, and ensure that everyone had access to an investigational product under expanded access protocols, or what WHO more commonly calls it as MURI, monitored emergency use of unregistered interventions, and then entry into the PALM randomized controlled trial. So in that outbreak, we were able to provide supportive care protocols that were made available to all clinicians working in treatment centers. We were able to make available the 2 monoclonal antibodies, as well as other, actually 4 investigational products at the onset of the outbreak through the expanded access protocols. So these, and the ones that continued after showing efficacy in the RCT were MAB114 and Regeneron EB3. And then, of course, integrating virus-specific therapeutic strategies with high-quality supportive care. So back to sepsis and filovirus, what are the clinical characteristics? Just to give a shout out to Dr. Shevin Jacob and Ian Crozier and others who contributed this important piece of work in the literature. And here's just a schematic of how they describe disease progression from Ebola virus disease. And just a note here, there is a need for more clinical characterization of disease. So, and I think many things are coming along the way from the recent outbreaks that are still in peer review and soon to be published. So watch out for that to understand the different viruses, but and headaches. So that can be complicated to diagnose early. So you do have to have, a good clinical acumen, followed by gastrointestinal symptoms, nausea, vomiting, diarrhea, and in some cases rash, and then progressing later onto the organ dysfunction symptoms such as hemorrhagic manifestations, renal failure, respiratory failure, neurological manifestations, and cardiac dysfunction, and unfortunately, in some patients, death. This is accompanied with clinical laboratory abnormalities such as elevated liver enzymes, elevated creatinine, and metabolic acidosis, high CPKs. And so with this, you can see that, the multi-organ dysfunction nature of this pilovirus-associated sepsis. And then here's another schematic from that same article showing the immune dysregulation. And I'm not going to go into this in detail, but just really the authors of this paper trying to suggest the mechanisms of impaired T cell activation, B cell and T cell dysregulation, excessive cytokines, and of course, leading to end organ dysfunction, capillary leakage, and third spacing, and damage to endothelium and shock. So we have a relatively rare fatal viral disease that needs to be recognized early, treated with supportive care, treated with proven therapies if they're available, or given investigational products under an RCT or expanded access protocol, and treated under strict biosecurity and IPC to protect health workers. So what do we do and what have we learned? The first is to make sure that the integration of the clinical care case management during the outbreak is part of an overall comprehensive response. So the treat really key, because what we really need to know is to stop the chains of transmission and detect early, and that's best done with good contact tracing for contacts. And then once they start to develop even the slightest of symptoms, bring them into care. The second is making sure that there is an adequate referral system, that there's adequate IPC, access to water, sanitation, and hygiene to deal with the waste that comes from caring for patients, that there's good with the community so that they accept care, that they come, and of course, a safe and dignified burial to prevent any ongoing transmission through unsafe burial practices. And in some cases here, I'm not going to be speaking about vaccination, but, of course, vaccines, which have been studied in multiple outbreaks, the use of vaccines as part of outbreak control. And in regards to case management and clinical care, we need to ensure quality and safe scalable care along the entire patient pathway, from early diagnosis to patient discharge. And here you can see the schematic starting on the left, early diagnosis and referral. So screening during an outbreak needs to happen at every point of access for health access points. So that means your clinics, your primary care clinics, as well as your hospitals and your emergency areas. And make sure that there's case definitions and people know how to screen, and make sure that they don't get too close or have direct contact with patients that are suspected, because that's where you can have, unfortunately, transmission to healthcare workers. And of course, community-based surveillance. So once a patient with suspected filovirus disease is detected based on case definition and good clinical insights, a referral system needs to be in place with ambulances that are dedicated to manage and transport these patients, because all the infection prevention and control measures need to be in place to take patients to the designated treatment centers or treatment areas. And then the treatment areas really need to be multi-specialty, interdisciplinary, providing clinical nursing care, medical care, obstetrics are needed, because we know females, pregnant women can be at higher risk for complications, pediatrics for the care of the children, and then of course intensive care specialty and expertise, emergency medicine expertise, amongst others. Complementary to that is the need for excellent, high-quality infection prevention and control, WASH, health logistics, operations, pharmacy, administration, HR, just like you would run any other treatment center, any other small, hospital or facility, to really make sure the delivery of care and the service delivery is top-notch, and then making sure the infrastructure to conduct a clinical trial and collect clinical data is there, and then follow up with a survivor program. So here on the bottom, you can see the importance of staff. You need well-trained staff. You need supplies, that the supply chain are working. You need a structure, and that's what I'm going to talk about shortly, the infection prevention and control, and then the system is in place. And all of this is integrated into the health system as well into the response. There are three areas that I'm going to focus a little bit on at this point. One is the design of treatment centers, no longer just an isolation center, but a center focused on patients, staff, families, and communities, where people can get high quality care and be safe. The second is optimized supportive care. This is doing the basics well, systematic assessment and monitoring of patients, resuscitation with oral and IV fluids. Point of care test is key, biochemistries, electrolytes, hemoglobin, and the use of oxygen, blood products, and other advanced intensive care interventions. And then finally, specific therapeutics. And it depends on what's the causative virus. So right now for Zaire Ebola virus, we do have two proven therapies that reduce mortality, MAB 114 and Regeneron EB3, but we don't have any proven therapies yet for Sudan Ebola virus or Marburg virus. So starting off with treatment center facilities, I wanted to show these three temporary facilities with designs that really aim to bring the green zone into the red zone. So the green zone is where it's safe to be without PPE, and the red zone is where, when you're with the patients, you have to be wearing full PPE. So on the left, you can see is the ALIMA cube, and this is a biosecurity emergency care unit for outbreaks. This has been around since I think 2018, and it's an isolated one-patient room where you can see there's a transparent screen where you can have medical equipment such as monitors on the outside, and just put the monitoring wires through entry points into the cube to connect to the patients. So you can be outside of the cube, see the patient really closely, and be also talking to the health workers that are inside the treatments, inside the cube, and also talking to the patients. And this allows closer monitoring and the implementation or the delivery of a more advanced clinical care. The middle is called the IDTM. It's the Infectious Disease Treatment Module. And this is actually a prototype done by the collaboration and partnership between WHO, the World Food Program, and multiple partners that are part of this partnership. And here it's kind of the cube, but a little bit more expansive with 2 treatment unit beds with the ability to provide critical care. And there you can see on the right, this is a simulation, so it's not an actual outbreak, but a mechanical ventilator with a respiratory tubing going through the transparent wall to go into the red zone inside where the patient's being cared for. And then on the right is the health emergency facility, and similar concept here. As you can see, the patients are beyond the transparent wall. You can see someone there with yellow PPE inside, and then the green zone where the green carpet is where you can be without PPE, again being very close to the patient but still protected, and so more visibility, which we think is key to optimize care, as well as to both from the medical perspectives, but also from the psychosocial, allowing family members to visit patients. So here we go on to the hallmark trial, the PALM trial, a randomized controlled trial of Ebola virus therapeutics that was conducted in the Democratic Republic of Congo. And just to acknowledge, this was the PI was Jean-Jacques Muyembe from the DRC, from the National Institute of Biomedical Research, and Cliff Lane from the NIH, and their teams, and together and collectively with many partners in the field, including WHO, as well as MSF, Lima, Samaritans, Perth, and others that were important actors at the time, conducted this trial. So this trial, if you look at the diagram, or the figure A, shows the bottom line results that MAB-114 and Regeneron reduced mortality compared to the standard of care, which was ZMapp at that time. And remdesivir was the other, broad spectrum antiviral that did not show any improvement over ZMapp. So here was the breakthrough results, and really nice to see this. And what's more interesting, was also very interesting, if you looked at figure B on the top right, is these are patients, subgroup analysis, patients with high viral load. And if you look at them, the MAB-114 and Regeneron EB3 also reduced mortality compared to ZMapp, but mortality remained extraordinarily high at 60 to 70%, whereas the mortality in the ZMapp group was as high as 90%. So you start to see, from this, what I showed you before, from the variability in mortality, is really to see why some patients really, it is a fatal disease when patients come in very late in disease with high viral loads. And figure C, we see patients with low viral loads. And here, of course, also interesting, the mortality in the Regeneron EB3 and MAB-114 as low as 10% in this group, whereas the ZMapp group and the remdesivir group remained higher, around 25 and 30%. So if getting patients earlier, really a good impact in reducing mortality. So from here, where are we? The mortality still remains high, and we still don't have treatments for Marburg and for Sudan Ebola virus. So WHO and my colleagues, giving credit here to the R&D blueprint under the leadership of Dr. Maria Henao Restrepo, published a Solidarity Partners platform adaptive randomized trial for new and repurposed filovirus treatments. And this is a core trial protocol that has now been launched in Rwanda last year, as well as was under process of getting approvals in Uganda. And it is a multi-country protocol that can be used across outbreaks. And because these are relatively small outbreaks in general, except for the 2 larger ones that I focused on, that it would require multiple outbreaks to recruit enough patients. And this is a nice study protocol. So here we are. So some therapies are proven, others are not. We know for Zaire Ebola, Regeneron EB3 and MAB-114 reduce mortality. So that's part of WHO guidelines. For Sudan, we do not have proven therapies, but MBP-134, which is also a monoclonal antibody, and remdesivir are under evaluation. For Marburg, we don't have specific therapies, but MBP-1114 and remdesivir are under evaluation. And of course, all patients, the foundation of therapy is optimized supportive care. And what is optimized supportive care? I'm not going to belabor this, but this is just doing the basics well. So in our SOP that we published in 2019, it's a daily checklist to monitor and facilitate early recognition of complications, really careful attention to fluid status and fluid management to make sure patients don't experience any early dehydration that is untreated, because patients do lose their appetite, they do get anorexia, and then progressively start to become dehydrated. Correction of electrolytes and glucose, treatment of co-infections, nutrition, psychosocial, and mental health. And this is all summarized in our optimized supportive care training available on the WHO Academy website. Contributed to this include many international experts and partners such as ALIMA, MSF, Samaritan's Purse, UNICEF, and more. So in conclusion, to optimize management of filovirus disease outbreaks, one is integration of clinical care case management into a comprehensive, well-coordinated response. Two is the early disease recognition and early treatment because that is associated with improved outcomes. Three is pristine infection prevention and control necessary to ensure safety for all health workers and patients in the filovirus disease care pathways. Four, innovative treatment-centered designs that are available and can enable safe and scalable care during the outbreak. Five, optimize supportive care, including critical care and treatment with proven therapeutics. And of course, access. When there is not a known therapeutic, we do encourage access to investigational therapeutics, but using available pre-prepared randomized controlled trials so we can gather data and then make policy. And if not able to do so that way, then use expanded access protocol with strict data collection on safety of these medicines. And then post-discharge is essential. So here, I just wanted to end with a few acknowledgments. When I was asked to deliver this talk, I thought back to what have I learned, and I've been going to these outbreaks since 2019, 2018 in the Democratic, and I've recently been to all the outbreaks I've described. And I just wanted to acknowledge here the group at the Democratic Republic of Congo team at the National Institute of Biomedical Research under Professor Muyembe that was responsible for starting the PALM RCT trial. And this is a treatment center that you can see on the right. And to give credit to Sabwe Mulango, who was the lead author on that paper, and to others that are in here, as well as to colleagues Ian Crozier, Billy Fisher, and Chevin Jacobs, who you guys may know, who are also pivotal in getting us supporting WHO to start up, supporting partners to start up this trial. And on the left, really the real-time use of this is during the outbreak in Beni, DRC, with Richard Kojan, who at that time was the president of ALIMA, and the teams in the cube taking care of patients with their PPE, and the others outside doing ultrasound, and myself there helping. And then most recently, to give credit, and just to show a few, again, the amazing work that's done collectively to respond to these outbreaks. And this is the outbreak in Rwanda. Again, a wonderful group here that was able to kickstart a trial during the outbreak, and clinical experts from WHO, and also acknowledgement to Luca Fontana, who's the lead here at WHO working on the treatment center designs, and then also support a call out to Dr. Mandy Rojek and Peter Horby, who actually were there to support the clinical research PI in Dr. David in Rwanda and the launch of this clinical trial. And thanks to my team and unit here at WHO listed here. So with that, I want to thank you for your attention, and wishing everyone a very successful meeting. The problem, the trouble, the need is large for sepsis, and the impact that we can make together can even be greater. But it's only with true collaboration, innovative thinking, ways of working, and commitment to taking one step at a time towards a common goal can we succeed. And I think that's actually what we were able to do with improving the care for filovirus disease patients during outbreaks. Thank you.
Thank you very much, Janet, for your fantastic presentation, because I can understand that this is a difficult task to implement in these countries, because we don't have too much time, because you exceed a little bit your time. One question that could be that in these countries where the outbreak have many patients and the system cannot support this specific and difficult management of these patients should be transferred to another countries. How this can be done? Because I can imagine a patient with an Ebola to transfer to United States. I think it could be difficult to do this, no?
Thanks, Antonio. It's a good question. I think in general, most countries and most of the national authorities prefer to keep all the patients in the country. And so a lot of the way the surge or the scaling of the care happens is through the entry of medical teams, like emergency medical teams, to support the country in the delivery of care, who can set up facilities quickly and provide the high standard of care. And so that's why there's a lot of NGO partners that have been involved in this in the past to do that and to scale the care on top of what the national government can do when necessary. And the other is if there was a need to transfer someone outside of there. And I think what we've been trying to do is to keep improving the quality of care so that you can get good care in the countries where the outbreaks are occurring. But if there was any, there is technologies of little transportation cubicles that you can ensure biosecurity and biosafety while you transfer the patient, and also be able to deliver, let's say the patient was critically ill, also be able to deliver critically ill, do a critically ill transfer of a patient, but within a module, which is like a smaller cube that I showed you, that would be one patient for transport. So those do exist, and we do train on those in case we have to do medical evacuations. For if a staff got infected and we had to make choices as to where the staff would get cared for, that's all planned for during the outbreaks. Over and thank you.
Okay, so thank you very much. I just to remember the audience that they can use the queue to ask questions to the speakers. The next speaker is Uzma Syed. She is an expert on infection diseases and global health. She has led during the COVID-19 pandemic in her medical field for the broad Muslim, American, and South Asian community as an infection disease expert on the National Muslim COVID-19 Task Force. And he was sharing also the COVID-19 Task Force at Good Samaritan University Hospital. I'm sure that she will present an excellent talk on providing quality sepsis care during global health emergency, lessons learned from the COVID-19 pandemic. So Uzma, is now your time.
Okay, thank you so much for that intro. Thank you to the Global Sepsis Alliance and for this amazing World Sepsis Congress. And today I'm going to briefly go through providing quality sepsis care during global health emergencies, lessons learned from the COVID-19 pandemic. I'm currently the Chief of Infectious Diseases at Good Samaritan University Hospital, prior chair of the COVID-19 Task Force during the pandemic. And we really want to just dive right into the global impact of sepsis. From data that we have, we know that there's approximately 50 million cases of sepsis globally and approximately 11 million sepsis-related deaths that occur worldwide. And this is, a really alarming number because we know that approximately 20% of global deaths are due to sepsis. Sepsis is responsible for 1 in 5 deaths globally, and at least half of those occur in children under the age of 5. So that is a really alarming statistic. Now, we also know that there's disproportionate impact of sepsis, and we know that the mortality rates can really vary by country, and we can see these disproportionate impact, especially in low and middle income countries. Now, what does sepsis do? We know that it can pose a significant strain on healthcare systems. We saw this during the COVID-19 pandemic, and we see this on a daily basis. You have increasing strain on hospitals. You see the cost of acute care. You see the need for ICU care, ICU staff, and everything that goes into the care to provide adequate care for a patient that, in fact, is presenting with sepsis. Now, not only do we have the acute care costs and strain on the healthcare systems, but post-hospitalization, sepsis also places a heavy burden on the healthcare systems, leading to increased costs of long-term rehabilitation, as well as loss of productivity, especially for patients. Now, the high expenditures of sepsis can affect the healthcare systems beyond the direct care of sepsis. And we can see that there's a lot of disparities that we can see in countries and in regions within a country because of limited access of healthcare services, inadequate sanitation, and poverty. We also know that sepsis oftentimes is underdiagnosed and underreported. And this was really the case during COVID-19. And we can see that the COVID-19 pandemic really magnified, really, truly the burden of sepsis worldwide. What are some of the long-term consequences that we have to worry about with sepsis? Now, we know that the acute phase patients are extremely ill, hospitalized most of the time, needing ICU care, but symptoms and disability can really persist long past the acute phase of illness. Approximately half of sepsis survivors experience long-term consequences. These can be physical, psychological, or cognitive, and some symptoms can be prevalent, such as chronic pain, chronic fatigue, post-traumatic stress disorder, anxiety, depression, memory loss, and impaired cognitive abilities. We also know that patients who are sepsis survivors have an increased rate of hospitalizations in the future. We also know that they have decreased quality of life and increased mortality. Well, viral sepsis is an entity that is really underdiagnosed and undertreated, and we saw this firsthand during the COVID-19 pandemic. Some symptoms that patients can present with include respiratory failure, multi-organ failure, and shock. And unfortunately, when healthcare systems are overwhelmed, we can see worse outcomes for our patients. And this is exactly what happened during the pandemic, COVID-19 pandemic recently, where patients that presented to the hospital with sepsis and septic shock especially, really had suboptimal care because of the strain that we saw in the healthcare system, and also because of the under-recognition and diagnosis of viral sepsis. What are some of the challenges that we had during the COVID-19 pandemic? Now, many of us in healthcare felt this burden on our shoulders, the weight of the world on our shoulders, and this uphill battle that we had, because we really were working with our hands tied behind our backs. We had limited resources. We had limitations in our isolation rooms, limitations in our ICU beds. We had limited ventilators, limited PPE, limitations in our staff, which we really need in order to provide adequate care for our patients, especially our patients that were presenting with sepsis. We had a lot of delays in diagnosis. We had limitations on testing. We had delays in our diagnosis of sepsis. As I mentioned before, viral sepsis was just completely under-recognized. We had this lack of experience with viral sepsis, right? We were using novel protocols for management of our sepsis patients. And we had so many barriers. We had infection prevention and control barriers. And all of these were really leading to the delay in care of our patients with sepsis. What are some of our lessons learned? We know that we need to use our best practices even during a pandemic. So we need to really ensure that we preserve our sepsis protocols. We need to use rapid diagnostics and screening tools to really have them be adaptable, not just for bacterial pathogens, but also for viruses. We need to really lean into those telehealth measures that we had to really aid in assisting in early detection and management. We need to provide flexible staffing. We have to be adaptive in times of emergencies and public health emergencies so we can really aid in our response teams. And we really need to ensure that we have stockpiling of our critical supplies. We saw this firsthand, our lack of amount of ventilators, PPE, fluids, antimicrobials, and so many others. I wanted to share just a few success stories. Different countries across the world really had better outcomes during the pandemic. We saw in South Korea, they had robust contact tracing, mass testing, and isolation protocols. They really relied on their digital health platforms and EHR integration. Their hospitals really maintained their standard clinical pathways, including early warning signs for sepsis. And what are the implications on sepsis? Well, early detection of infection really allowed them to have more timely intervention, reducing the progression of patients to severe sepsis. In Germany, we had high ICU bed capacities. We had a coordinated private-public health system response, and they maintained their continuity of care for non-COVID critical conditions, including sepsis. And so the implications for our septic patients were that they had better resource allocation that ensured that sepsis protocols really stayed intact even during surge periods. In New Zealand, we saw that they had swift border closures and centralized pandemic response, and they really put a priority on their community health and prevention measures, and they were able to maintain normal hospital operations longer than many other countries. Implications for our patients with sepsis is that they had fewer COVID hospitalizations initially, and they could really adhere to standard sepsis response and bundles. A hospital in Sweden had adaptive clinical protocols for COVID-induced sepsis, and they really emphasized their multidisciplinary care team approach, and they used electronic sepsis alert systems throughout the pandemic. And implications for sepsis patients was that they had flexible team-based care, which allowed the hospital to really recognize and treat sepsis early, even in COVID-19 patients. At Mount Sinai in the United States, they launched AI-based early warning systems for sepsis and deterioration, and they had real-time analytics and dashboard which track COVID and non-COVID deterioration patterns. And they continue to run sepsis education for frontline staff even during the pandemic. So what happened as a result is that this technology really played a key role in really mitigating this delay in recognition of sepsis. Now, we know that there were many places locally, nationally, basically throughout the whole world, which had unfortunately really poor outcome during COVID-19 for many of our sepsis patients. The screening tools, as I mentioned before, were paused or really deprioritized every time we had a COVID-19 surge. We know that early on in the pandemic, emergency room visits decreased by about 50%. And this is really significant because a lot of care was being delayed. So patients with early signs of sepsis that really needed to be seen in an adequately fashion had delays in their care. We saw a really significant increased rise in community-acquired sepsis-related deaths, and we saw these in the extremes of ages, in the really young and the really elderly population, and especially our immunocompromised population as well. What happens when our healthcare system is overwhelmed? Well, we have many things that are contributing to this, and this is all leading to worse outcomes for our patients. We had limitations of isolation beds, as I mentioned before, ICU beds that patients needed, especially patients that had COVID-19 associated viral sepsis, limitations in oxygen, limitations in PPEs, and just medications that we needed to treat our patients. We also saw the disproportionate impact, especially in rural regions, where we had the delays in the referral and treatments. And all of this really led to a dramatic increase in sepsis-related mortality, both in our COVID and our non-COVID related cases. In the US, we saw a lot of hospitals really disrupt their SEP systems in place, and they suspended them. And unfortunately, this led to a lot of reduction in monitoring of time to treatment benchmark. And all of this just led to increased sepsis-related mortality, especially during the COVID-19 pandemic. Now, what are some things we can look at for innovation and how we can move forward using technology, using what we have at our fingertips to really advance our care, especially for sepsis patients and especially during a public health emergency? Well, AI and predictive analytics can really be used for early sepsis prediction. We can really rely on electronic health records data to really improve our care for our sepsis patients to provide that early care and intervention. We can utilize mobile sepsis carts, and we can use that to really deliver bundles at an adequate time fashion and swifter, because really that's what we need to do, is time is everything when it comes to sepsis. And we can continue to use simulation-based training for all of our healthcare providers to make sure that the staff is adequately prepared to care for patients with sepsis, especially during a public health emergency. So some things we should focus on moving forward for our futures, because we know that this is not going to be the last public health emergency. We need to make sure that sepsis care is embedded early on in any pandemic preparedness plan. We need to maintain core sepsis education and awareness in every emergency response. We need to ensure resilient supply chains for key medications and tools. And we need to always include sepsis metrics in emergency dashboards. So this is really important, as I mentioned, because of healthcare crises that we will continue to see, whether it was a COVID-19 pandemic or the next public health emergency that we have. We just need to focus that sepsis care should not be paused, even in the height of a public health emergency, because we know in the end, this is going to have worse outcomes on all of our patients and the community at large. So finally, what are some of the things that we can focus on to ensure that we have quality care during a crisis? Well, we look at the lessons learned from the COVID-19 pandemic, and we really look at the cost of diverted attention, the significant mortality that we had because of that. We need to make sure that we integrate sepsis protocols into every emergency response so that we can adequately save more lives. And we really need to focus on this last question that we should be asking ourselves is, what are some of the steps we can take to ensure that sepsis care is not sacrificed during the next public health emergency? Thank you.
Thank you very much for your excellent presentation. I'm sure that we will have a new outbreaks of a virus or other diseases, especially now today, where there are many problems in the world with many wars, etc., and difficult to live in some countries right now. My question is, one of the problems that I remember in the COVID pandemic time is the the lack of physicians and nurses, and as you mentioned, it was necessary to train all the physicians in the hospital to take care of the more severe patients. Do you think that this will have some impact in the future and to prepare, to be better prepared for the next pandemic?
Yeah, that's an excellent question. And I think, unfortunately, this is a reality that we're going to have to face again. We're not really in any better place now than we were before the pandemic. And it's unfortunate because many people have left healthcare because of as a consequence of, what they went through during the pandemic. And I think we have to really start focusing on our support staff and what we can do to better assist them and support them in every aspect, not just in regular time, but in, a time of public health emergency when there is so much strain on the hospital and healthcare systems and all of the staff that is in turn affected by this. We have to really restore the trust in public health and really focus on what are the needs of our staff at the time of emergencies so that we can be better prepared and really start building, building that right now. We need to ensure that we're thinking of the future, not just that we're fully staffed now and we'll be fine, but are we ready to go when there is that public health crisis and that global pandemic and emergency, because we saw how poorly we did the last time around.
Okay, so thank you very much. We don't have more time, and there are no questions in the chat. So thank you very much for your excellent presentation, and we will move for the next speaker. Next speaker is Mohammed Elfatih Ahmed. He's the Vice President of the Sudanese Sepsis Alliance and the Champions of Sepsis Awareness and Care Improvement regionally and globally. He's working in the Ribat University Hospital and critical care fellow at the Sudan Medical Specialization Board. And he's the chairman of the Acknowledged Translation Committee at the Al-Tababa Advanced Health Solutions and serves as a protocol consultant for Sudan's Federal Minister of Health. I'm sure that you will present an excellent presentation, especially because you are very close to your Minister of Health, and probably you will recommend some things to all of us. So now is your time.
Thank you for the kind introduction and amazing moderation. My presentation will be about vulnerabilities in providing quality services for sepsis care during war, experience from Sudan. Sepsis already is a life-threatening emergency in a normal condition, becomes more even devastating in the context of war. As Professor Cornell mentioned in the first session, that sepsis mimic war. Both of them have devastating consequences in the systems, in the body for the system and in the systems of the country. So in Sudan, the health infrastructure collapse, the supply shortage, and there is insecurity. And this turned the basic principle of timely and effective sepsis care to near impossible. Today, in my presentation, I will go beyond the statistics. I want to humanize this struggle. So I will starting by this picture because it's a picture reflecting hope. So it's a team of health workers performing emergency operations in total darkness, guided only by beam of mobile phones, flashlights. This isn't just a scene, it's a symbol. It reflects the daily heroism of the front lines providers who continue to serve despite unimaginable condition. The mobile light cutting through the darkness is not only a source of illumination, it's a message for all of us. Even in our most vulnerable moments, there is always light at the end of the tunnel. So the war began on April 15, 2023 due to rebellion by the Rapid Support Forces, RSF, sparking intense fighting in Khartoum and across many states. Over 10 to 12 million people displaced, creating one of the world's largest humanitarian crises, with more than 2 million crossing into neighboring countries. Continual violence led to an unprecedented humanitarian, health, and economic crisis, deeply affecting individuals and the healthcare system alike. That's why we move from the traditional thinking to systems thinking. So the RSF targeting the Health Institute, around 70% of hospitals were out of service with supply chain collapse and many attacks for many hospitals in the Sudan, and even the only big maternity hospital, it targeted twice, even after repair, is targeted by the RSF. So hospitals converted into military barracks, and there is major losses in specialized centers. For example, cardiac care centers are lost, an estimation financial losses around $83 million. And even losses in the dialysis and kidney transplant centers, and the figure is already displayed in this screen. And 200 ambulance and more than 179 four-wheel drives looted or stolen. And unfortunately, even the damage for the pharmaceutical sectors, over 60% of pharmacies and warehouses were looted or destroyed by the RSF. This is the base of Student Sepsis Alliance. It's in my university. It's one of 100 universities and research centers were looted and destroyed. And the war has disrupted the medical supply chain, leading to critical shortage of antibiotics, IV fluids, and other essential needs for sepsis care. Many pharmacies and hospital stores have been looted or exhausted. Without appropriate antimicrobial and fluids, clinicians are often unable to follow sepsis protocols, resulting in suboptimal care. And disruption in sanitation lead to outbreak of cholera, dengue fever, and measles, and sharp rise in acute malnutrition among children under 5 compared to 2018. The estimated total loss in health sector is $11.4 billion, covering buildings, medical equipment, furniture, ambulances, consumables, and medicines. And the odd thing that the RSF is targeting doctors. A number of doctors were arrested or abducted or killed. The human loss, over 12,000 deaths and 33,000 injuries recorded in hospitals, with 870 deaths recorded in Maternal Health Institute between April 15, 2023 and 2024. And the health worker losses, over 60 health professionals were killed, including doctors, nurses, lab technicians, ambulance drivers. Massive migration of health professionals abroad, leading to critical shortage, especially in the conflict-affected area. This is one of the eminent professors, not just local, even internationally. He's a gastroenterologist killed for nothing. And this is Dr. Sir Khatim Awad. Even he is shot deadly by the militia, the RSF, on his duty in Al Medina Arab Hospital. And these incidents highlight the volatile, unpredictable nature of this militia, where even areas considered relatively secure can quickly become dangerous. So access to care is severely limited, and many patients must endure long journey. For example, pregnant women in war zone often give birth at home without skilled help, greatly increase the risk of sepsis, hemorrhage, and other complications. Timely diagnosis of sepsis is extremely challenging in Sudan war zones. Without lab confirmation, clinician must rely on clinical sign alone. And this diagnostic lab or gap leads to missed or late recognition of sepsis and delaying life-saving treatment. Many patients with infection symptoms cannot seek help early due to insecurity or lack of transport. By the time they arrive at hospital, if one is functioning, their infection may have progressed to sepsis or septic shock. Ambulance calls and referral coordination are frequently impossible during network blackout. And even the ambulance service are crippled and relatively fear traveling on a dangerous route. So at-risk patients remain at home. Even link in the emergency referral chain is fragile, leading to deadly delay in treatment. Many sepsis require intensive care and close monitoring, which is largely unavailable now in Sudan. And this is a sad story for a patient called Miriam. Miriam delivered at home with only a neighbor to help. the unsanitary condition led to infection of the womb. By the time relatives managed to get her to clinic, Miriam was feverish and delirious, and the clinic lacked antibiotics and had no surgeon. Miriam died of postpartum sepsis, leaving behind her newborn. And newborn babies are dying in shocking numbers, observed an MSF health manager, describing the situation as multiple health emergencies happening simultaneously with almost no international response. In South Darfur, many infants were born in displacement camp or enrolled to hospitals with infection settings due to poor sanitation and lack of prenatal care. 48% neonatal deaths, 0 referral options, and 100% preventable. This is a testimony from Aisha. She's a nurse surviving the attack on her clinic in West Darfur. She lost the access to crucial medical supplies and equipments, but her staff using makeshift methods by boiling instruments to sterilize them, and they determined to find a way to resume operation and to serve. At the hospital in Omdurman, one of the few open in Greater Khartoum, doctor faced a flood of emergency cases. And behind these statistics, real people who live hanging the balance amid of Sudan healthcare collapse. Here is, despite the immense challenge, local and international actors are working on creating solutions to improve sepsis care in Sudan. And there is a diaspora and local initiative. Sudanese medical professionals abroad have mobilized to fill the gap. The Sudanese American Physician Association, SABA, and other diaspora groups have helped to rehab damaged hospitals and fund operating costs. And even the SABA supported reopening of Saudi Hospital, which is the one of only 2 providing maternity care at that area. And Sudanese Sepsis Alliance launched telemedicine clinics, and even doctors in Qatar upgraded the Port Sudan teaching hospital with telemedicine service. So with many specialist doctors evacuated from the war zone, telemedicine became a key tool. Even simple WhatsApp group used for sharing TB protocol or getting second opinion on patient management. In one case, in a rural doctor managing a child with septic shock, also due to meningitis, he received guidance via satellite phone from a pediatric intensivist overseas, adjusting fluids and medication which improve the child's outcome. And in the lower corner is example for software that we use in dealing with the clinic or virtual clinics. We use AI individually, not as a system, to interpret the medical image and test, and it can quickly flag signs for pneumonia on chest X-ray from the AI. But we are working now with soft engineer Ihab al-Mahi, who created this software to integrate the AI-driven early warning score for sepsis, which may help our doctors to early recognition of sepsis. Mobile clinics almost is in a joint effort by WHO and Federal Ministry of Health. And this clinic often set up to repurpose building or undertakes to provide basic primary emergency care and even the treatment option for common infection, wound care, maternal health service, and some have capacity for minor surgeries and sepsis management on site. Community, Sudanese community have created network to overcome drug shortage and information gap. It's called WAFRA. It's a social media-driven initiative where volunteers share real-time updates on where medicine are available. And international organizations like WHO, UNICEF, and Red Crescent and MSF have brought in kits containing antibiotics and intravenous fluids and antiseptics, and there is a vaccination campaigns and mobile surgical teams, but still these efforts insufficient and need to scale up because of the growing humanitarian crisis in Sudan. This is a success story. The Sudanese Sepsis Alliance launched not less than 8 campaigns in 8 states in 2023 in the middle of the war, and even in 2024, and successfully we raise awareness about sepsis. So let's come to the policy recommendation and future roadmap. All parties, international actors, must work to stop attacks on healthcare and to improve coordination to relieve efforts. And for sepsis, this means that if one hospital lack need for drug oxygen, a system in place to source it elsewhere, and most importantly, to protecting health worker is equally critical. So we advocate that the UN and the African Union level and even the Global Sepsis Alliance to continue to highlight attacks on healthcare in Sudan. And even amid the war, we should make a train and equip local health worker with better skills to recognize sepsis, to support creation of solar power, to help in oxygen concentration and hospital, to provide service, and to collaborate with tech companies and research institutions to bring in telemedicine platform or portable ultrasound and AI diagnostic system base to support as a pilot in Sudan. So also you look up for scale up essential supplies and service by establishing protected route for delivery antibiotic apheresis and diagnostic kits, and to support setting up mobile clinics and field hospital, and to pre-position emergencies like sepsis kit containing medication and fluid to treat sepsis patients and deploy these to hotspot. And behind every statistic, believe me, there is a human story, and the most vulnerable population bear the heaviest burden of sepsis in war settings, with preventable death occurring daily due to system failure and resource gap. Here is a roadmap for actions, and we positively hope the war will end soon. We need immediate response to scale up emergency medical supply, humanitarian corridors, mobile clinics, and provide direct financial support to functioning facilities, medium-term stabilization by strengthening coordination mechanism, expand community health worker program, implement telemedicine network, and develop context-specific sepsis protocol, building resilience by investing in training programs, support local manufacture of essential supply, develop AI diagnostic tool, and create sustainable funding mechanism. And lastly, system reconstruction plan for post-conflict rehab of health infrastructure. So in conclusion, the international community and Sudanese stakeholders together must act with urgency and creativity to shore up sepsis care amid this war. The goal is not only reduce deaths in Sudan now, but also to build a stronger health system for future and ensure that in any war, no one is left to die from a curable infection due to indifference or inactions. In appreciation of all Sudanese medical staff, the Council of Arab Ministries awarded the 2024 Arab Doctor Award to the Sudanese doctor. And where system fails, humanity rise, and leadership shed a light for a pathway for all of us. This is Dr. Kamal. In this spirit, I would like deeply to appreciate Dr. Kamal, the president of Sudanese Sepsis Alliance, who is now on the field within the war. His work hardly to rebuild intensive care services and raise national awareness about sepsis, providing that leadership is not about position, but about purpose. And the Federal Minister of Health, Dr. Haitham, whose vision and unwavering commitment in the face of chaos have made him a symbol of resilient leader, guiding the nation's health response with courage and clarity. And here is his call to reconstruct hospitals destroyed by the war, and even he still declared to continue the national sepsis policies in Sudan. When there is war, healing is possible, hope is stronger than fear, and we believe Sudan will never die. Thank you.
Thank you very much for this impressive presentation, and to congratulate you for all the work that you are doing to try to improve the situation, the terrible situation in your country. Probably the best and appropriate treatment should be to stop the war, no? Because the situation is terrible, and as in other countries where they are already, they have also terrible war where many people are paying with their life about this phenomenon, no? And I hope that you will be successful reconstruction all the health facilities in your country when the war will stop, and I hope that you will also receive the support from other countries to try to help your country. So thank you very much. It was very impressive, your presentation, and I'm sure that many people will learn a lot on your experience. Now we need to move to the next presentation. This will be by Julia Syed. Jihan has an experience on United Nations, and he is specialized in health systems and addressing also maternal and newborns and reproductive health that need in fragile and crisis settings. So, Jihan, now is your time.
Thank you, Professor Artigas. Hello, everyone. Good morning, good afternoon, and good evening. I'm here today to speak about how humanitarian agencies can help prevent the disruption of essential services, sepsis services, for preventing, identifying, monitoring, and managing sepsis during a humanitarian crisis. And this is a crucial topic, one that doesn't always get the attention it deserves. So I'm looking forward to sharing some of my reflections and hearing your thoughts as well. So last year, while I was on a work assignment in a crisis-affected setting, I stepped into a district hospital that was supposed to be a lifeline for both mothers and babies. Instead, I saw a scene that was absolutely shocking. I could even say inhumane. This hospital, one that hundreds of people depend on, had no functioning sinks in critical areas, no clean gloves for healthcare providers, and no proper infrastructure to manage dangerous medical waste. And as a result, the risk of sepsis in this hospital was quite disproportionately high. And I remember speaking to the maternity head, and she looked at me and said, "We do our best, but we're also overwhelmed and frustrated. We don't have enough staff, we don't have enough supplies, so every day we're forced to improvise and take risks, because if we don't, more patients will die." And I agree with her. Without enough staff or supplies, you can't just sit there and wait for the situation to resolve itself. You have to intervene with the limited resources you have. Unfortunately, the consequence of this is that it can only last so long before health facilities become a breeding ground for the spread of infections. And I can say this because I've seen similar situations before. During conflict, disaster, and displacement, essential health services, including those to prevent, detect, and manage sepsis, they're often the first to be disrupted, leading to unnecessary complications and unnecessary deaths. You see, in many parts of the world, health systems are already weak and fragile. So when a crisis hits, health facilities either collapse or they become too overwhelmed to provide even the most basic care. The absence of reliable surveillance systems during a crisis makes it even harder to track and monitor sepsis cases, which often results in delayed or poorly targeted interventions. On top of that, health facilities capable of providing sepsis care during stable periods, they often do not prioritize it during crisis. And this is because they lack emergency protocols, they lack plans, they lack policies that would support the rapid and organized delivery of sepsis care. Besides that, poor coordination among different health actors is another major issue. It often leads to fragmented sepsis response with a lack of clear leadership. There's no one agency or two agencies that clearly takes up the role. There's often overlapping responsibilities between agencies and insufficient communications between partners at country levels. So to prevent the disruption of essential sepsis services, humanitarian agencies, they must tackle these challenges. They must address them to build health systems that are actually ready, resilient, and responsive to all. Luckily, we don't have to guess what works. I've seen health facilities that, despite having limited resources, they have sustained services and they reduce the risk of sepsis, even through repeated crises. What did they do? They invested in infection prevention. They trained staff to identify sepsis early, and they implemented clear, easy-to-follow protocols. So when a crisis hit, those facilities, they responded faster, they saw fewer severe cases, and they faced less burden on critical resources. So we know what works. We have seen the difference between health systems that crumble in a crisis and those that remain standing. And it all comes down to being prepared, not waiting until a crisis unfolds before we actually respond to it. So in my view, there are three critical steps that humanitarian agencies must take to strengthen health systems and deliver adequate sepsis response. The first is to make infection prevention and access to water, sanitation, and hygiene a top priority. This means stopping infections before they start by ensuring all facilities have clean water, fully equipped hand washing stations, and a safe way to dispose of medical waste. Also, humanitarian agencies, they must ensure quick and reliable tests to detect infections. This includes implementing systems to track infections, monitor trends, and adjust interventions in a timely manner. Frontline healthcare workers, they must also be trained to recognize sepsis early, and referral systems to specialized care must be improved. On top of that, humanitarian agencies must secure sustained access to essential medicines. They need to improve medical supply chains and fully integrate sepsis management into crisis response. This includes pre-positioning emergency stock, streamlining procurement, and coordinating with critical partners to prevent sudden disruptions that may impact the delivery of sepsis care. So we've talked about the problem and we've also talked about the solution. Now I want to focus on the action it takes to translate those solutions into sustainable outcomes. And this really comes down to one key commitment that is required from humanitarian agencies. They must prevent the disruption of essential sepsis services by making sepsis prevention, early identification, monitoring, and treatment a core priority into every humanitarian crisis response. Sepsis exposes what is broken in a system, but it also gives us an opportunity to step up and act to save lives. When I see a health facility with high sepsis cases, it often tells me that infections are not being managed on time. And it also tells me that policies are either not in place, or if they are, they're not being fully implemented or sufficiently funded. And this is quite a loss because a policy on paper means nothing if it's not backed by action to save lives. And every one of us has an important part to play in this critical process. First and foremost, donors, they must provide flexible funding that allows sepsis prevention, identification, monitoring, and treatment to be fully integrated into humanitarian health programming. I encourage them to collaborate with key leaders, for example, the Global Sepsis Alliance, which is well capable of bringing key actors together and has dedicated an entire pillar to sepsis in emergencies in its 2030 global agenda for sepsis. Policymakers, they must ensure that sepsis management is fully integrated into national health budgets, emergency preparedness plans, as well as accountability frameworks. Without any serious political will and planning, health systems will continue to fall short when a crisis hits. And at the operational level, health authorities, they must take charge of translating policies into action by ensuring that existing emergency plans are diligently being followed and that clinical management of sepsis is provided across all levels of care. Sepsis care, because it is cross-cutting, it cannot be excluded from the essential health services package. It must be delivered as part of it. So I would say also to ensure a coordinated response, humanitarian agencies, they must act swiftly to fill in system gaps. They need to coordinate every emergency response. For example, organizations such as UNFPA, they have successfully integrated infection prevention into health services during crisis. Also, healthcare providers, they must be equipped and supported to implement evidence-based guidelines on sepsis, infection prevention, and AMR in alignment with WHO standards and adapted to the national and subnational context. Equally important, communities, they must be engaged and informed because awareness, early care seeking, and trust in healthcare systems, they are absolutely essential to reducing preventable morbidities and deaths. For those seeking more information on sepsis, I of course recommend the Global Sepsis Alliance websites, which has great resources. And if you're interested in initiatives to advance maternal and newborn health globally, I encourage you to visit the website of Align MNH for more insightful resources, including on maternal and newborn sepsis. So before I finish, I'd like to leave you with one final message. I believe that sepsis care can remain strong, even in the face of the toughest emergencies, but that can only happen if we create an environment that is truly prepared, that is ready to tackle the unexpected. It is possible to succeed in delivering adequate sepsis care during emergencies if donors fund it, policymakers prioritize it, health authorities implement it, and humanitarian agencies act. When that happens, we can prevent the sudden disruption of sepsis care, we can save and protect lives, and we can build the sustainable, resilient health systems that the people truly deserve and have a right to. It is their human right. So let's work together to make that happen. Let's use our voices for good and call for systems change. Thank you very much for listening. It was an honor to be here today, and I gladly return the floor to you, Professor Artigas.
Thank you, Jihan, for your, I will say, optimistic view. And I think it's very important to have this view, because if we are not trying to improve our system, then the disaster will not finish, will never finish, you know. I hope that we will find many donors, probably some from USA, to invest money to improve the care and the outcome of patients with sepsis, especially in the low and middle income countries. So thank you very much. So next speaker is Fani Kalala. She's an immunologist and hematologist and an assistant professor of medical immunology at the medical school at University of Esli. And his current research including on High Horizons project focusing on climate, and health of mothers and children.
Yes, thank you very much for the invitation. Well, my topic is completely different to the previous ones, and undoubtedly, sepsis is a leading cause of maternal and child mortality worldwide. In recent years, climate change has emerged as a global threat and is linked to increased mortality in both children and women. But the impact of climate change on maternal and newborn sepsis outcomes is understudied and poorly understood. There are very few studies that have been conducted so far concerning the impact of climate change on maternal and newborn sepsis outcomes. And the message of my presentation, I would like it to be to highlight the utmost need to perform more studies and the importance of their conclusions. So let's start by seeing what sepsis pathophysiologically has had a long journey up to now. And basically, when we talk about sepsis, what we should think about is that it represents an altered immune response, a dysregulated immune response against a pathogen. So what is the function of our immune system and why this dysregulation is so important? The primary function of our immune system is to maintain good health and to protect the body from dangers. These dangers can be pathogens, allergens, toxins, or malignant cells. On the other hand, the climate is the overall average weather at the place over a period of time. Climate change is the long-term shift in global and local weather patterns, primarily caused by carbon emissions and the greenhouse effect. So when we talk about climate change, basically what we mean, or what we should also think about, is the rise in temperature and air pollution, the change in the quality of our air. Climate change has an undoubtedly big effect on human health, and it affects human health in many different ways, especially infections. We will see that effect a bit later on. And if we think of sepsis as a life-threatening organ dysfunction caused by the dysregulated host response to an infection, you can see that it is affected by both host-derived factors, which include the environment, and in this case, climate change, but also pathogen-derived factors, which are affected by climate change as well. As a consequence, climate change has changed the pathogens with increased viability, increased range, increased access. It has changed their vectors, and it has changed the host by many different ways, socioeconomical ways. All of these combined have the emergence of new infections, new cases in new places, and with great severity. And bear in mind that the immune system we all possess as humans has evolved through the years under certain environmental conditions, that is, under a certain climate. So the climate changes. The big question is, will the immune system adapt to that change? And as a consequence, how will it act on sepsis? All humans, we have an exposome, the environment as in climate change, a genome, our inflammasome, all three combined help us fight infections. And as you can see, as the environmental stress increases, so does the incidence of sepsis and other diseases increases as well. Who is the most vulnerable populations that are affected by both sepsis and climate change are, of course, pregnant women, mothers, newborns, and children. They are affected in more than one way, not just pathophysiologically, but also in a social economic level as well. And although there has been a big step towards the treatment of sepsis through the years, sepsis has not vanished and is among the leading causes of mortality in both mothers and children. To that, we add the harmful effect of climate change as depicted here by the rise of temperature. The rise of temperatures seems to be harmful for our health and for infections. And taking into account the past 2 decades, the rise in temperature, if we look at lower income countries, we see that in the countries that have suffered the greatest rise in temperature, the greatest rise in mortality affecting children is noted as well. If we think of sepsis in the sense of infections as well, we see that extreme heat and wildfire smoke is affecting it as well. And this is a very important study conducted in Bangladesh, proving very well the impact of climate change on mortality, on the incidence and mortality of sepsis in children. It is a retrospective study. They have gathered data from records from a big hospital in Bangladesh from 2009 to 2022. It doesn't give information only about newborns, but also about children in all ages. Bear in mind, 60% of the population of the study is children under the age of 5 years of age. And they correlated the incidence and mortality of the hospitalized children to environmental factors, especially to the temperature and the precipitation levels. And what they found is really astonishing. They proved a nonlinear relationship between temperature and sepsis incidence and mortality as well. Given a cutout for temperature as 26.6 degrees centigrade and a sharp rise above this temperature is linked to a great incidence, an increasing the incidence of sepsis, as well as participation levels. And if we combine both, so we have a rise in temperature and precipitation levels, we have a higher incidence of sepsis in the hospitalized patients. That is the same stands for mortality. So when we have a rise in temperature and precipitation levels and their combinations, we have more mortality in the hospitalized patients. Strikingly, they also showed that if the exposure to high precipitation and higher environmental temperature is 2 weeks before the illness, that's linked to higher sepsis incidence and mortality as well. So we really need more studies like this to be able to conclude and have safe conclusions. Hopefully, in the future, in the following years, the work done by the High Horizon Consortium examining how extreme heat affects maternal, newborn, and child health will be able to give concise evidence on the impact of heat on maternal and newborn sepsis outcomes. And lastly, although there are many voices out there concerning climate change, at the end of the day, climate change is a reality and we all experience it. It affects all of us. It seems that the challenge of modern life is having a properly calibrated immune system. Whether our immune system will be able to adapt along with climate change, microbes, and sepsis is still to be seen. Thank you very much.
Thank you very much for your excellent presentation. Now we are moving from the war now to the climate changes. I have a question, especially for elderly patients that they have, normally these patients are immunodepressed. Do you have any recommendation or any information on the temperature relationship of the temperature of the climate change and elderly patients?
That's a very good question. Elderly people are affected as well, and because they also have chronic illnesses. So we don't have studies conducted so far concerning elderly people as well. So the recommendations are the same as in the general population.
Okay, so thank you very much. So thank you very much for your presentation, and I would like to thank all the speakers for the fantastic presentations that I hope that this will be very useful and informative to all the audience, especially in those countries where they are supporting the wars with the terrible situation, especially for septic patients. So thank you very much. And again, thank you for all the sponsors and the Global Sepsis Alliance for this initiative to organize this session. Thank you.